Hello and welcome to Trauma 840. I am Ms. Gardner, and today we are going to be discussing an integrated trauma treatment approach. And I hope you all find this information rather informative and useful to your careers as counselors and future counselors. Cognitive processing therapy, CPT, will be discussed as to portray its effectiveness for the purpose of treating individuals that have been diagnosed with post-traumatic stress disorder, PTSD. However, prior to concluding thoughts, a Christian worldview perspective will be incorporated as to demonstrate its usefulness when combined with CPT. By the end of this presentation, students will be able to define CPT, identify goals of CPT, identify stuck point and proper CPT protocol, and finally, comprehend the effectiveness of CPT and Christian worldview implications associated. The history of humankind is not only a story of art, science, and culture, but it is also about war, interpersonal violence, oppression, and a plethora of disasters, both natural and human caused. What is cognitive processing therapy, CPT? CPT is a cognitive behavioral treatment. It is evidence-based and is said to be effective when working with PTSD clients and a number of other disorders, inclusive of sexual violence. CPT allows trauma survivors to identify stuck points. This approach then fosters a more positive self-perception as the client comes to reinterpret former bad behaviors, deservingness of maltreatment, and presumed inadequacies in a more accurate light. What are the goals of CPT? The goals of CPT seek to improve PTSD symptoms and associated symptoms one may have, such as depression, emotional numbing, avoidance, anxiety, guilt and shame, as well as the quality of overall daily living. Is CPT empirically supported? When working with interventions, it is imperative to know if the chosen modality has been tested. In terms of CPT, yes, it has been tested. CPT is said to be empirically supported in its effectiveness among individuals with PTSD who have fought in wars in Iraq and Afghanistan. Who benefits from CPT? CPT was originally developed for people not just with the PTSD, but with additional disorders and conditions. CPT can be used with individuals from 3 months to 60 years after their traumas, and some clinicians are using it even earlier in crisis situations such as combat, domestic violence, refugee work, and sexual assault. In addition, CPT can be used for individuals with minimal formal education and for people with IQs as low as 75. In addition to the previous slide, I would like to add that it is imperative to know that CPT is not just for people with PTSD, but it is effective also when working with female rape victims, childhood sexual abuse survivors, victims of intimate partner violence, refugees, incarcerated adolescents, and combat veterans. What are stuck points? Stuck points are said to be inaccurate beliefs about the causes or consequences of the traumatic event that hinders recovery. Specific areas to challenge stuck points may include self-blame and guilt, power and control, and self-esteem. Self-blame and guilt are said to be perpetuated by cultural beliefs and by negative reactions from others in the survivor's life. Individuals who incorporate negative social reactions into their overall view of themselves tend to have the highest levels of PTSD symptoms. With power and control, doing an act of sexual violence, an individual is said to be stripped of his or her power, and often survivors continue to feel powerless and out of control long after the trauma has ended. Counselors can assist the client in focusing on restoring his or her sense of personal power, particularly regarding decisions made in the present. In terms of self-esteem, in the client's CPT treatment manual, it is recommended for clients to focus on the effect that the sexual trauma has had on their views of themselves. Clients' answers to these questions can help to uncover automatic negative thoughts, such as, I am unlovable, or I am damaged goods. Other areas that may experience hardship are the trust and intimacy area. Because sexual violence often is committed by someone the survivor knows and trusts, a client's capacity for intimacy and ability to trust may be disrupted. If a survivor questions his or her judgment in selecting safe relationships, engages in self-blame, and receives victim-blaming reactions, he or she can develop particular problems in trusting both self and others. To change these stuck points, clients can explore beliefs they have developed related to relationships and about the world in general. For example, people are bad and can't be trusted. The world is unsafe and unfair. They can change those beliefs that are impediments to their recovery, evaluate current relationships and their interactions with others who can provide support, and fully explore the need for positive connections with others as part of the recovery process. Before CPT treatment begins, there is a pre-treatment assessment process, which consists of gathering information and determining client index trauma. First, the clinician must establish the client does in fact have PTSD, and a comprehensive history of trauma events should be a part of the intake procedure. In this step, mental health professionals will also determine the client's index trauma. And by index trauma, it means the traumatic event where the client is experiencing the most PTSD symptoms. Secondly, after the index trauma has been established, mental health professionals should assess for PTSD with an interview and a self-report scale. The purpose of using a self-report scale is so that the clients can be trained to answer the questions, focusing on the index traumatic event rather than general life stressors. Most individuals with PTSD present with at least one comorbid condition or clinical problem. In fact, CPT has been tested with a wide range of individuals with these co-occurring issues. That said, it is important for a therapist to consider these other conditions as well as the client's individual case conceptualization and to help the client manage them in order to profit most from CPT. Other comorbid conditions may include depression and substance use disorder. With psychotic and bipolar conditions, the therapist should liaison with client psychopharmacologists and other treatment providers, ensuring that they are aware of the initiation of CPT and informing them to be observant of any changes the client may present. Risk for self-harm to self and others. Clients should pursue therapy as long as no suicidal or homicidal ideations are in place. However, the therapist should monitor for changes in risky areas and have a safety plan in place. As persons with comorbid disorders are not excluded from CPT, it is essential that therapists be mindful of personality disorder traits that can affect the therapeutic process. Sleep disturbance can be addressed during this stage as well. Clients should remain on medication, and family involvement is imperative as it has been proven to be effective in the treatment process. When assessing for PTSD, Three commonly used assessment tools are the clinician-administered PTSD scale, CAPS, the PTSD checklist, PCL, and the life events checklist, LEC. CAPS is said to be the most comprehensive for assessing for PTSD symptoms, and while the assessment takes about 50 to 60 minutes to complete, it does have impressive reliability and validity. The PTSD checklist, PCL, is a 17-item self-report measure designed to assess both symptoms of PTSD and severity. It can be used for screening individuals with PTSD, diagnosing PTSD, and assessing symptoms change during the treatment process. Also, the Life Events Checklist, LEC, is said to be a 17-item self-report measure that is designed to screen for potentially traumatic events. When preparing to deliver CPT, there are some essential techniques the therapist must be skilled in, which are Socratic dialogue, clarifying questions, and challenging assumptions. Socratic dialogue is very important at this point, as it helps to bring the client into a healthy appraisal of the traumatic event and the effects of those traumatic events on the here and now appraisal situations. The practice involves the clinician asking a series of questions and valuing the power of individuals coming to know something new for themselves versus being handed an insight or knowledge from another. The therapist should be asking many clarifying questions at this point as to set the stage to what was happening at the time of the index trauma event, bringing to light what choices and abilities the client may have had available at the time, as opposed to what the client thought about later in the situation. Finally, the therapist must be able to ask questions aimed at challenging the assumptions that are underlying client's conclusion about the traumatic event. This is where the just world belief that good things happen to good people and bad things happen to bad people, and that the world should be a fair and just place should be challenged. However, if some clients do not subscribe to the just world order, there is no need to push the notion of the just world. Other areas therapists should be skilled in include the ability to evaluate objective evidence and challenging the client's underlying or core beliefs. Evaluating evidence is said to be aimed at helping clients evaluate the evidence that may or may not support their conclusions of the traumatic event. Persons with PTSD are said to have a cognitive bias toward the perceived threat and negative information more generally. Thus, clients will have this type of information more readily accessible to them and may overvalue this information relative to data that do not necessarily support their conclusions. Clients may sometimes say that, I hear what you are saying, but, or I know what you are saying doesn't make sense, but it feels that way. It is imperative for mental health professionals to consider possible reasons that may be preventing their client from completely embracing alternative ways of thinking. How does CPT work? CPT treatment begins with psychoeducation regarding PTSD, thoughts, and emotions. The patient becomes more aware of the relationship between thoughts and emotions and begins to identify automatic thoughts that may be maintaining the PTSD symptoms. The patient writes an impact statement that details current understanding of why the traumatic event occurred and the impact it has had on beliefs about self, others, and the world. Next, the patient begins a more formal processing of the trauma or traumas. The patient writes a detailed account of the worst traumatic experience, which the patient reads in the next session to try and break the pattern of avoiding thoughts and feelings associated with the trauma. The therapist will continue to use Socratic questioning and other forms and strategies to help the patient question his or her unhelpful thoughts about the trauma. For example, self-blaming thoughts, in order to modify any maladaptive thinking. Finally, once the patient has developed skills to identify and address unhelpful thinking, She or he uses those skills to continue evaluating and modifying beliefs related to the traumatic event. At this point, the therapist is helping the patient develop the ability to use these adaptive strategies outside of treatment to improve overall functioning and quality of life. Therapists may particularly focus on common themes such as safety, trust, power, control, esteem, and intimacy, as these are all areas that can be affected by traumatic experience. Keep in mind that these themes will also be discussed further in the presentation. How is CPT delivered? CPT can be delivered both individually or in structured group sessions. Regardless of modality, clients will have out-of-session practice assignments. In fact, CPT was said to be originally developed with written trauma account as one component of treatment. CPT is delivered in 12 sessions and aims to help patients learn how to challenge and modify unhelpful beliefs related to the trauma. As we mentioned earlier, CPT is delivered in 12 sessions. In this section, we will go over the goal for each session, as well as the procedure for each session. So the goal in the first session is that clients come to understand what exactly PTSD is, how they got stuck, and what CPT will do to put clients on the path to recovery. The therapist will describe symptoms of PTSD and the theory of why people get stuck in the recovery process. Cognitive theory will be described as well. This involves helping the clients come to understand the cognitive model of emotional and psychological disorders, followed by a discussion regarding the role of emotions in trauma recovery. Next, and very briefly, the index trauma will be reviewed and then describe all the overall course of therapy. Give the first practice assignment, and the therapist will end by checking the client's reaction to the session and answering any questions the clients may have about the session. When intrusions occur, the natural emotions and arousal run their course, and thoughts are said to have an opportunity to be corrected. As we can see by the image, in a normal recovery fostered by positive emotions, intrusions and emotions decrease over time and no longer trigger each other. However, in those who don't recover, strong negative emotions such as aggression, self-harm, social withdrawal lead to escape and avoidance. The avoidance prevents the processing of the trauma that is needed for recovery, and it works only temporarily. Here is an example of what a practice assignment will look like after the first session. The client will have an opportunity to write about their feelings and what they think caused the event. The client is asked to write at least a one-page statement on why he or she think their most distressing event occurred, and will bring it to the next session where it will be discussed. The goal of session 2 and 3 are to review the impact statement each client has written in their first practice assignment, with a primary intent to find stuck points that have impacted recovery. Session 2 involves the following: revising the client's scores on the self-report objective measures, have the client read his or her impact statement aloud and assist the client with identifying those stuck points. If the client failed to complete the impact statement, the therapist must address non-adherence with the impact statement. Help clients identify connections among events, thoughts, and emotions, learning to differentiate facts from thoughts and describe stuck points. Also give new assignment at this point. Entering to session 3, the therapist will want to review completed assignments from the last session and then introduce the ABC worksheet. This will help clients to become their own cognitive therapists by heightening awareness and how their thoughts influence their behavior. Describe and discuss stuck points, give new assignment, and the therapist will want to check the client's reaction to the session and the new assignment. Here's an example of what a therapist's stuck point guide looks like. Stuck points are concise statements that reflect thoughts, not feelings, behaviors, or events. They're usually phrased in if-then format. When clients provide what they think are stuck points, but are not in stuck point format, Socratic dialogue can be used to clarify the underlying stuck points. This slide provides a copy of the client's stuck point log. This will be used throughout the therapy sessions. The client will add to it or cross off thoughts that they no longer believe. A copy of the ABC worksheet is provided on this slide. The ABC worksheet will assist in becoming more aware of the connections between events, thoughts, and the client's feelings. Sessions 4 and 5 involves ensuring clients can label events, thoughts, and emotions and can see connections among them. Session 4 examines the index event by first reviewing the client's scores and the self-report. Therapists are also to review the client's ABC worksheet and address assimilated stuck points, after which the therapist should introduce the challenging questions worksheet and hand out new practice assignment, while also checking clients' reactions to the session. Session 5 involves reviewing the challenging questions worksheets and introducing the patterns or problematic thinking worksheets to the client. Sessions 6 and 7 involves teaching clients to become their own cognitive therapists by asking the questions with the patterns or problematic worksheet. Session 6 begins by reviewing the client's scores on the self-report objective measures and conducts a mid-protocol assessment. The client's pattern of problematic thinking worksheet is reviewed at this point, followed by an introductory of the challenging beliefs worksheet. Allow clients to practice and complete with a trauma example. Disseminate new practice assignment and check the client's reaction to the session. Session 7 involves reviewing the client's challenging beliefs worksheet from the previous session to determine comprehension. An overview of what was discussed. Introduce the safety, which is the first of the themes that will be discussed in the next sessions. Practice assignment is disseminated and reactions to the session is checked. Sessions 8, 9, and 10 involve safety, trust, and power control themes. Session 8, safety, was discussed in the previous session. Therefore, the therapist will review the client's challenging beliefs worksheet related to safety, after which the trust theme will then be discussed. Session 9 will review the client's scores on the self-report objective measures, as well as the challenging beliefs worksheet related to trust and to other stuck points, and then introduce the power control theme, give practice assignment, and continue to check clients' reactions. After which, in session 10, the therapist will review the client's trust star worksheet, as well as the challenging beliefs worksheet related to the power control theme and other stuck points. The esteem theme will then be introduced, followed by a new practice assignment and continuous checking of the client's reactions to the session. We have now come to the end of our CPT sessions. Sessions 11 and 12 begin by reviewing the client's self-report scores, as well as challenging beliefs worksheet related to the esteem theme and stuck points. The therapist should review assignments regarding compliments and nice, worthwhile things the client has completed, discuss therapy termination, after which the intimacy theme should be introduced, followed by practice assignment and continuing to check the client's reactions to the sessions. Aftercare is very important. It is imperative to provide adequate patient follow-up. Thus, after the CPT protocol has ended, the therapist should always set up a follow-up appointment for a month or 2 in the future. Follow-ups are important as they track compliance. The follow-up should include the same assessment measures that were used during the treatment and can be used to get the client back on track or enforce gains. Please see in your handouts in-depth information relating to sessions procedures. As we recap regarding CPT, we want to be mindful and remember that CPT is in fact a cognitive behavioral treatment. It is evidence-based and said to be very effective when working with PTSD clients and other comorbid disorders. CPT seeks to improve PTSD symptoms, as well as stuck points and inaccurate beliefs that hinders a client's healing and recovery. As CPT seeks to change distorted beliefs that keep individuals stuck, it does resonate profoundly with the Christian worldview of thinking and healing. The Bible states, "Be not conformed to this world, but be ye transformed by the renewing of your mind, that ye may prove what is that good and acceptable and perfect will of God." Like CPT, in order to heal and recover from trauma, the mind has to change. And spiritually, if believers are going to grow, there has to be a change in one's thoughts and focus on things that are true, things that are honest, just, pure, lovely, and good. While CPT has been proven effective and works well on its own, it certainly has spiritual implications and can be extremely beneficial to clients that desire an explicit spiritual approach. In fact, new studies have integrated spirituality and CPT, and results appear promising. However, to further shed light on the effective abilities of CPT when also combined with spiritual implications, we will look at the case of James. He presented at the VA for treatment, and upon evaluation, he had scored 57 on the PTSD checklist, military version, and described various war-related traumatic experiences on the life events checklist. He also reported experiencing flashbacks and nightmares, among other symptoms, since returning to the United States 1 year ago. The traumatic experience he named as most troublesome for him was doing something bad on a convoy he commanded. James also shared that his Christian faith was very important to him, although he found it hard to practice as actively as before his deployment. Upon learning of the option of engaging in spirituality integrated cognitive processing therapy, which is a new treatment for PTSD that also targets moral injury, James chose this treatment approach, and after only 12 sessions, his PTSD checklist score registered at 31, indicating comparably reduced symptoms, and fell under the cutoff of 35 for a probable PTSD diagnosis. James is very happy and willing to share his experience with spiritually integrated CPT with his veteran friends who were also stuck and living with guilt and shame. He was happy to know that using resources of his Christian faith would help him to find that healing he needed from his traumatic past. In closing, it is imperative to reiterate that CPT is an empirically supported treatment modality for treating clients that have been diagnosed with PTSD and other comorbid disorders. It has shown great success with populations who have experienced child sexual abuse and other forms of sexual violence. As it seeks to eradicate stuck points that hinder healing and recovery, new studies have also shown its effective use when also spiritually integrated. Thank you so much for your time and attention, and it is my hopes that this information will guide you in your counseling careers, but also that you will allow Christ to work through you, that great work will be done in bringing healing to those that are suffering. Thank you.